And now,
Okay, so pneumonia. So pneumonia is an infection of the lower respiratory tract. It's caused by bacteria, viruses, fungi, protozoa, parasites, and it's the 8th leading cause of deaths from infection in the United States. It's responsible for more disease and death than any other infection. It can be categorized as community acquired, healthcare associated acquired, or ventilator acquired, and that includes the hospital acquired, right? So hospital acquired is defined as occurring in individuals with recent hospitalizations, like with a residence in a nursing home, a long-term care facility, that sort of thing. Those at most risk are smokers, alcoholics, and people with nutritional deficits or already immune compromised, right? So there's 2 different types. There's viral and there's bacterial. Well, the viral is infecting viruses that include influenza, adenos respiratory syncytial virus, and the pathophysiology is usually a complication of the upper respiratory infection in which the virus spreads to the lower respiratory tract. The virus destroys the activated epithelial cells and it invades the goblet cells and the bronchial mucus glands, right? So that sloughing is destroyed by the mucus glands, and that bronchial epithelium impairs the mucus clearance by the cilia. So they can't cough all that stuff up and it just sits there and kind of keeps breeding, right? So in the bacterial, the infecting organisms include gram-positive bacteria and gram-negative bacteria. Examples of gram-positive bacteria would be the Streptococcus pneumoniae, Klebsiella, forgive my pronunciations, pneumonia, Staphylococcus aureus, and then the gram-negative would be like E. coli, gross, Pseudomonas, Haemophilus species, Proteus species, and Bacteroid species. The pathophysiology with that is as bacteria multiply and the inflammatory process progresses, the pus accumulates. So again, it's just getting nastier and nastier, and that would lead to why it's like the 8th leading cause of infection, because a lot of people think it's just a common cold, and meanwhile it's just brewing and it's getting nastier and nastier and more viscous, right? So the results in a process of consolidation in which the alveoli become filled with pus. So we all remember like our bronchial trees and then the alveoli, and those are all just sitting there festering. The body's defense mechanisms, in addition to the inflammation, include coughing to expel that pus, which then leads us into the signs and symptoms, right? So you have the affected individual, they're going to usually look like that toxic appearance, like they're just not in a good place. They're going to have fever, they're going to have malaise, of course the productive cough, because their body's trying to naturally expel that stuff. And there may be respiratory distress and hypoxia. You can't breathe. Your oxygen's not adequately perfusing through your alveoli and your bronchioles, and you can't circulate it, right? So of course you're not going to have good adequate breath intake. So the etiology of pneumonia is the development of hospital-acquired pneumonia, which is really what I want to touch on with the ventilator-associated pneumonia. And that represents an imbalance between the normal host defense and the ability of microorganisms to colonize and then invade the lower respiratory tract, which is, that's what we've been talking about. So the other symptoms are going to include chills, again, that malaise, and pleuritic chest pain, which here's the kicker. Now we need to differentiate, is this left ventricular heart failure, or are we really having pneumonia? The physical examination is going to reveal signs of pulmonary consolidation, such as that inspiratory crackles. Remember Rice Krispies? I don't know about you guys, but that's how I always remembered it. Increased tactile ephrematus. Remember, you can palpate and feel the chest vibrations. The egophony, the prolonged ah over when the chest, the consolidated areas, when the patient's really saying E. And the whispered ventriloquy, the sound of that whispering heard on auscultation over the consolidated lung tissue. So now we lead to that evaluation and treatment that we were discussing. The diagnosis is made on the basis of history, physical examination, white blood cell count, and the measurement of procalcitonin, or the C-reactive protein. And of course, always, always, always a chest x-ray. Stains and cultures of blood and respiratory tract secretions are completed in a more severe in hospital cases and the start of antibiotic therapy. Remember, don't ever start antibiotic therapy before you draw those blood cultures, because if you draw those blood cultures and then start antibiotic therapy, are you really getting an accurate reading? Serum procalcitonin, or C-reactive protein levels, can be used to help differentiate that bacterial from viral infection, but you need to, it'll help guide the therapy, But usually you won't start antibiotic therapy unless it's greater than 20 millimoles per liter. We'll get to that here more in a minute. So once the diagnosis of pneumonia has been made, the pathogen is identified by means of the sputum characteristics, remember, like your gram stain, the color, the odor, that sort of thing, and cultures, or if sputum is absent, blood cultures. Because remember, we want to go non-invasive first. We're always taught non-invasive before we get more invasive. So if they can't expel sputum for you, you're going to have to rely more on those blood cultures, because you don't want to do bronchial wash on a patient. Like if I were to go in with pneumonia, that's more invasive. Let's see what we can do that's non-invasive. Remember how we talked about differentiating between cardiac heart failure and pneumonia? Well, you're going to do an echocardiogram and sometimes even a ventilation perfusion scan just to help differentiate between the two. The microbiologic approach to diagnosing ventilator-associated pneumonia include preferred non-invasive methods, just such as I've been discussing, such as collection of spontaneously expectorated samples, sputum production, if I can cough that stuff up for you, and nasotracheal suctioning. That's not that invasive. We can do a little bit of rinse and suction out to try to get some of the good stuff that's really going to have the true bacteria back there. If the patient's intubated, endotracheal suction is acceptable and is considered non-invasive. So treatment, right? So the first step in the management of pneumonia is establishing adequate ventilation and oxygenation. Remember your ABCs, airway, breathing, circulation. If they're not breathing, what's the point of all of this, right? So we want to make sure that we're getting them adequate ventilation, especially since all of that's being suppressed right now. Adequate hydration, I'm always preaching hydration, and good pulmonary hygiene, like deep breathing, coughing, and chest physical therapy, they're also important. So get your respiratory therapist, they'll be on track with you. Do that physiotherapy, help break it all up, help come up so they can cough it up and get it out of there. Antibiotics should be given within 4 hours of any initial treatment plan diagnosis. Like, you think they have pneumonia, let's get those antibiotics going. Let's get it started immediately. The sooner the better. Empirical antibiotics such as Zosyn or ampicillin are used in ventilator-associated pneumonia. And according to the 2014 National League for Healthcare and Excellence, the recommendation is to give only antibiotics when the C-reactive protein is greater than 20 millimoles per liter. Boy, that's a tongue twister. And positive clinical findings are present. Antifungals such as fluconazole may also be necessary. Prevention. Well, how can we prevent this from even happening in the first place? Prevention measures include prevention of aspiration, respiratory isolation of immunocompromised individuals, vaccines. Anybody over 65 years old, ask them if they want that vaccine. Let's help give them that little bit of push. And reduction of ventilator-associated pneumonia can be done through a variety of methods, such as the oral intubation, or the endotracheal intubation, the intubated patients. Let's just get to that. The intubated patients, you want to do oral mouth care. And that's it. And that's it. That's pneumonia in a nutshell.